Welcome to this video presentation about the medial collateral ligament of the knee. My name is Mark Schmitz. I'm a lecturer of anatomy, physiotherapy and musculoskeletal ultrasound and founder of the Anatomy and Physiotherapy Facebook page. In this three-part video presentation, I'm discussing a few topics. In part 2 and 3, the biomechanics and examination of the medial collateral ligament are explained. At the end of each part, I will provide you a link to the reference list of the articles I used. But first, part 1. The anatomy of the various layers of the medial collateral ligament. The knee is a modified hinge joint that must allow flexion and rotation, yet provide complete stability and control under a great range of loading conditions. The knee consists of two joints, the femorotibial joint and the patellofemoral joint. The bony architecture of the femur, tibia and patella contribute to the stability of the knee joint, along with static and dynamic restraints of the ligaments, capsule and musculature crossing the joint. The medial femur condyle has a rough surface. The anatomical rule, form follows function, can be applied on this matter. Evolution made several small tubercles which act as attachment sites or anchors to ligaments and muscles. The medial collateral ligament, as from now referred as the MCL, is a broad, flat band about 8 or 9 cm long. It can be divided into 3 tissue layers: the posterior oblique ligament, the superficial MCL, and the deep MCL. These ligaments have multiple interconnections to the joint capsule, the muscle tendon units like the pes anserinus and the medial meniscus. More pictures about these interconnections will be presented in this presentation. Obviously, this is the medial side of the knee, because we don't see a fibula, which is located on the lateral side. Several soft tissues attachment have been highlighted. The adductor magnus tendon, coming from superior and inserting on the adductor tubercle, which is located at the distal edge of a thin ridge of bone called the medial supracondylar line, along the medial aspect of the distal part of the femur. The medial gastrocnemius tendon, originating from the gastrocnemius tubercle and posterior knee capsule, and then going to inferior. And the superficial MCL, often referred to as the tibial collateral ligament, and its attachments now marked in red. It originates on the medial aspect of the femur, proximal and posterior to the medial femoral epicondyle, here marked in yellow, then courses distally and attaches distal to the medial tibial plateau and anterior to the posterior-medial tibial crest. So it has 1 femoral and 2 tibial attachments. Between these two distinct tibial attachments, the superficial MCL is separated from the tibia by an artery, a vein, a nerve branch from the tibial nerve, and some fine facial and adipose tissues. The majority of the distal attachment is located within the pes anserine bursa and forms a large portion of the posterior floor of this bursa. The posterior aspect of the tibial portion of the superficial medial collateral ligament blends with the distal tibial expansion of the semimembranosus tendon along its distal aspect. At the green markings, you can see the attachment sites for the deep MCL, which has 2 subdivisions: meniscofemoral ligament, of course on the femur, and the meniscotibial ligament on the tibia. On this slide, you can see the attachments of the superficial and deep MCL. Notice the connection between the medial meniscus and the deep MCL. We zoom in on the 2 subdivisions of the deep portion of the MCL. First, the meniscofemoral ligament of the deep MCL with attachments at the mid-portion of the peripheral margin of the medial meniscus and the medial femoral condyle. And we have the shorter and thicker meniscotibial ligament with attachments at the medial meniscus and the medial tibia plateau. The names of these ligaments have been clearly defined by their respective insertions. The posterior oblique ligament is a continuation of the MCL and a reinforcement of the posterior-medial capsule. The posterior oblique ligament consists of three fascial attachments that have been termed as the superficial, the central or tibial, and the capsular arms. The superficial arm of the posterior oblique ligament consists of a thin fascial expansion. The central arm is the largest and thickest portion of the posterior oblique ligament. The capsular arm consists of a thin proximal fascial expansion of the anterior aspect of the distal part of the semimembranosus tendon. The capsular arm primarily blends with the posterior-medial joint capsule and the medial aspect of the oblique popliteal ligament. It is also attached to the medial gastrocnemius tendon and the adductor magnus tendon. Qualitatively, it is less stout overall than the central arm, and it hasn't got any osseous attachments. This photograph and illustration demonstrates the central arm of the posterior oblique ligament. The asterisk indicates the femoral attachment of the superficial MCL, which has been removed. See the interconnection of the central arm with the semimembranosus tendon. Here you can see a photograph of the femoral attachment of the adductor magnus tendon and its fascial expansion to the medial gastrocnemius tendon and posterior-medial capsule with underneath the posterior oblique ligament. The metal forceps is holding the anterior edge of the superficial MCL. It is clear that distinct structures can't be seen. It's all interconnected, which will have, of course, consequences for clinical reasoning in case of a trauma. That multi-tissue interconnection can also be observed in this transverse section of the femur condyle. Note the connection between the superficial MCL, the deep MCL, and the posterior-medial complex. See also that these structures are a thicker continuation of the more posterior and anterior capsular fibers. In this transverse section at tibia level, the interconnection with the semimembranosus and the MCL can be seen. Okay, I hope that after seeing these slides you have a better three-dimensional anatomical picture of the MCL. In part 2 and 3, I will discuss the biomechanics and examination of the MCL. The list with the 46 used references can be downloaded for free at kinecare.nl. The default language of the page is Dutch. Click the little flags for English or German. Click Education, and after entering the page, again, Education. Choose in the scroll bar Social Media and download the reference list. One long edition of the three-part MCL video presentation can be viewed at the Anatomy and Physiotherapy Facebook page, where the newest ideas, pictures, videos, and latest evidence-based information about anatomy and physiotherapy are posted on almost a daily basis. High quality and spam-free. Please like us. This video presentation has been made by Kinecare, specialists in anatomy and musculoskeletal ultrasound with a special interest in the shoulder girdle. Thank you for your attention and see you next time.